Some people get confused and they think that implantation failure or infertility is pregnancy loss, so that's been linked to APS as well. That's wrongly, but it has been linked. And then there's miscarriage, which is my particular interest, and miscarriage, which just means the spontaneous loss of a pregnancy before 24 weeks. And it can be divided into sporadic miscarriages or recurrent miscarriage. And the importance here for me to emphasise to you is that it's the women with recurrent miscarriage. I'm going to get a crook in the neck if I stand up there. It's the women with recurrent miscarriage that are linked with the phospholipid syndrome. And once again, it's really important that we ensure that we are all talking about the same thing. So if we're defining recurrent miscarriage as 3 or more pregnancy losses, and that's the definition that I'm using, and the definition we tend to use in the UK, that problem affects about 1% of couples. If we define it as 2 or more, then the problem affects 5% of couples. Now, 1 and 5% may not seem a big difference to you, but actually it means the difference between investigating 1 in 100 couples who are trying to have a live baby and 1 in 20 couples who are trying to have a live baby. And not surprisingly, the difference between having 2 or 3 miscarriages really does change the emphasis on what the underlying cause is going to be. So if we investigated everybody with 2 or more miscarriages, we wouldn't find that many people with APS. When we investigate them with 3 or more, we find about 15 to 20% of them have APS, and that's a very important one. Now, relevant to a talk about pregnancy loss, I think, comes from our understanding that actually problems in pregnancy are on a spectrum of disorders. And that just as important as the miscarriages early and the miscarriages late in pregnancy are those late pregnancy complications such as growth restriction and preeclampsia and preterm delivery. And so this very simple chart, I think, summarises it all. One bar chart just demonstrating that the problems in pregnancy are a spectrum which may start in the first trimester with first trimester miscarriages, go on to be second trimester losses or late pregnancy losses or early preterm deliveries and stillbirths, and then third trimester complications. But, and this is the important bit, they all have a common etiology or a common blueprint at the time of implantation. So the quality and the depth of the way the placenta implants in early pregnancy determines whether you have an early miscarriage, a late miscarriage, or whether you go on to suffer a baby with growth restriction and preeclampsia. Now I'm generalising a bit, but you get the concept that it's a spectrum that we need to be really concerned about. And as I mentioned earlier, there's a difference between sporadic and recurrent miscarriage. I don't need to go over that. But the other point I want to emphasise to you is particularly relevant, I think, when we first started looking at APS in recurrent early miscarriage, is that miscarriage that we see, or declares itself, is the tip of the iceberg. And that underneath the surface of the water, there are a large number of subclinical pregnancy losses that we never used to know about. We're much more aware of now because, of course, most people carry home pregnancy tests in their bathroom cabinet. They don't have to wait for 8 weeks to go and see the GP, or in my mother and grandmother's generation, they had to have 3 period visits before they were even thought about as being pregnant. Now women will screen themselves on day 26 or day 27 of the cycle, and when the little pink or the little blue line, depending on what you've bought, comes up, they know they're pregnant. So large numbers of pregnancies that are underneath the surface of the water. So the problem is a large one. And the other point that I wanted to emphasise to you is that women who present with recurrent pregnancy loss are a different group of women reproductively from women who have had normal pregnancy outcomes. So this is a study that was done by one of my research fellows who's now my consultant colleague, and it was done a long time ago, as you can see, over 15 years ago. But what she did was she looked at all the women who were presenting to the clinic, and we're looking here at 500 women, and of course all of them had had 3 or more miscarriages, because that was the referral criteria by which they came to us. But then look at all these other problems that they had. Nearly a third of them had problems getting pregnant. They weren't infertile because they'd come to miscarriage clinic, but they had problems getting pregnant, and many of these problems were ovulatory problems. And a very large percentage, about a fifth of them, had had a late miscarriage as well as their early miscarriages. Now that figure of 22% may not seem very important to you, but if I explain to you that if we take all the pregnancies in the UK this year, only 1% of them will be late miscarriages. Now this figure is dramatic. And of course, you won't be surprised to hear me mutter as an aside that many, many women in this group of late miscarriages had hospital syndrome. And then if you look down here, they had the higher incidence of ectopics, terminations for abnormalities, and very importantly, a lot of the women that I see have had a live pregnancy in the past and then repeatedly miscarried. But interestingly, if you look back into that pregnancy, a very large percentage of them have had the complications. So if you go back to that previous slide where we looked at these late pregnancy complications, they've had a live birth, but they've been complicated by problems in the mother, such as preeclampsia, or problems in the baby, such as growth restriction. So here's the syndrome, and I'm sure that the previous speakers have defined it, but I, of course, am emphasising it for the current miscarriage that presents to my clinic. I very rarely see women who've had a thrombosis, even if they are hospital positive, and I rarely see people who've had thrombocytopenia or what have it. So again, emphasising my first point, it really is important to understand where the patient population is coming from. And you know all about this, the prevalence, but I'm going to emphasise to you that about 1 in 6 or 1 in 7 of the couples who walk in saying, I've lost all my babies, they're going to have this syndrome. And this is an audit that we do every 2 years. It comes out with the same figure of 15 to 20%. And these patients are very, very treatable if you can identify them. And I heard Alice talking about the pros and the problems and the pitfalls or the caveats of screening, and they're no less applicable to the women who come for this kind of research. I would emphasise though that if I was in Dr. Hunt's clinic, was it Professor Hunt? Professor Hunt. She would probably be poo-pooing anyone with IgM targeted antibodies. This is possibly not necessarily that important, or perhaps she's not. But what we found in the miscarriage clinic is that women who have lupus, women who have IgG or IgM targeted antibodies, all of them are at risk of miscarriage, and all of them are potentially treatable. And I think this understanding has been, and this treatment work that I'm going to tell you about briefly, has been very successful, and it's led to us redefining the obstetric criteria that allow people or allow physicians to be able to access testing. So we don't just confine it now to 3 consecutive miscarriages. We also suggest that we should screen women who have unexplained loss of a baby that's measured or is bigger than 10 weeks size, i.e. weight loss, and one or have had a preterm delivery before 34 weeks, which has been associated with very severe preeclampsia or placental insufficiency. So when it's only one pregnancy loss, but it's associated with all sorts of placental abnormalities, then we're suggesting that we should screen these women too. Now, how do we treat them? So if 15% of these miscarriage patients have got this problem, compared to 1 to 2% of the normal population, and if there's a very high loss rate of these pregnancies, in the region of, I would say, 90% in the first trimester, and the underlying cause is thrombotic one, then not surprisingly, the treatments that were studied and became the ones that we most use are those that are anticoagulant or thromboprophylactic. And here I'm summarising years and years of many, many clinicians' hard work in one simple 3-line slide. And in summary, as you well know, I think, aspirin and heparin therapy significantly improves the live birth rate for these women who present with recurrent miscarriage, who are found, 15 to 20% of this population with miscarriage, to have the hospital clinic. And there have been a variety of studies that have been done, and they've all come up with roughly the same figures of a live birth rate between 70 and 80%. Safety relates to the fact that we have, in medical terms, what we say, unpredictable pharmacokinetics. That means that if we all have the same dose of warfarin, we all get a different blood thinness, and as you all know, if you alter your diet, if you alter what you drink, if you alter your drugs, you also have to alter your dose of warfarin, and if you don't, you've got a risk of bleeding. So, a difficult drug to manage, and we've got quite a high risk of bleeding. And when in the 70s the low molecular weight heparins came through, which is dalteparin, clexane, tinzaparin, Inahep, all the other ones, they were a major advance because they have predictable pharmacokinetics, which means that if we all got the same dose Clexane, we all had 40 milligrams, we'd all get the same blood levels.
and they'd be the same in all of us all through the day, and that they'd all go up and come down. So we don't need to monitor. Terrific, but not convenient, because you have to give low-level heparins through an injection. And they have a different set of side effects. So, we're really excited about the new oral anticoagulants because they have predictable pharmacokinetics. That means that if we all have one dose of the tablet, we'll all get the same blood levels and they'll remain the same day after day, not affected by food, not affected by alcohol. And the magic words for me: fixed dose, no need to monitor, no trips to the anticoagulant clinic, throwing coagul checks away. Makes me smile. And I think about the 1 million people there are in this country who are on anticoagulation, going to anticoagulant clinics. And there's real excitement because not only are they convenient for you, but they also look like they work better and they have a better safety profile. They cause less bleeding problems. So, do we have the prospect of the better treatment and better quality of life? And if we compare them, this is medics, so a bit too much, but if we compare them, I just want you to look at onset of action. So warfarin takes days to work, which is why you normally start off on a heparin, because that works straight away. Look at onset of action. Rivaroxaban, dabigatran work within 30 minutes. Isn't that amazing? So you could take that after you'd had a blood clot and you wouldn't need to have injections until the warfarin worked. Yes, there are some drug interactions, but they're quite small and specific. They relate to drugs to treat people who have HIV and some of the antifungal drugs and some things like digoxin or whatever. So I am saying to you, we are at the dawning of a new age. I would love you all to be off warfarin and on a new oral anticoagulant. But we're not sure what to do with you if you have a big bleed. So maybe those old anticoagulants aren't so bad. I'm starting to reevaluate. I think actually warfarin ain't that bad because we can reverse the warfarin if you were bleeding at the end of the needle, and you're reversed within a few minutes. Maybe it's right that we should let the rest of the world have a look at the new oral anticoagulants, and we can learn from them when NICE approve these new drugs over the next few years. So what are we doing in antiphospholipid syndrome? Because we need to have a look at them, and there is no data at all. Nothing. And really, all of the trials have been comparing the use of the new oral anticoagulants against an INR of 2 to 3. I know most of the audience here know what INR 2 to 3 means. Nobody has done a trial and knows what dose to use if you're running an INR of 3 to 4. It's never been looked at, and I would think most of the room probably running an INR of 3 to 4. So we're going to start looking at rivaroxaban, which we think is probably the best in antiphospholipid syndrome. Here at St Thomas's with University College, we've been sponsored by the Arthritis and Rheumatism Council, and we are very gently and tentatively going to look at safety. And I don't know who here might have had a deep vein thrombosis in the past, but we will be looking at patients running an INR 2 to 3 who have antiphospholipid syndrome to see how they get on before we move on to very complicated patients or patients who run an INR of 3 to 4.